Hello, everybody. We're going to go ahead and get started. Thank you for joining us today. My name is Renee, and I welcome you to the library this afternoon. And I would also like to welcome our viewers who are watching via live stream. If you would, please note the feedback forms that are on the back table and share your thoughts with us about today's programming. Your feedback helps us plan for any future events. Today's talk is part of a medical topic series throughout 2025 that the library is proud to offer with UAMS Family Medicine and the College of Medicine. The series will feature doctors, social workers, nurses, and other medical professionals presenting valuable information on a variety of health-related issues. We have a calendar on the back table of the programs that are scheduled for the rest of 2025. After a break in July, the next talk will be on Friday, August 8th, and the topic will be on diabetes. It's my pleasure to introduce our speaker today, Dr. Alan Padilla-Ramos. He is a family medicine physician at Family Medical Center in Fayetteville. His talk today will be about post-traumatic stress disorder, and thank you for being here again.
All righty, well, good afternoon. I'm Dr. Alan Padilla-Ramos, as said, and we're going to talk about PTSD today. It is a complex subject. I'm not a psychiatrist or a psychologist either, so I have a very narrow view of this condition and the treatment, but I'm going to go over the broad spectrum of it. Let's start with what it is. So what is PTSD, or post-traumatic stress disorder? It's complex somatic, cognitive, affective, and behavioral effects of psychological trauma. This is just reflecting of how complex it is because it's just somatic, which means the part of our body, cognitive of our brain, affective of our emotion, and behavior of our relationships. So it really affects all of our system after experiencing some trauma. Now, what is trauma was the next question, and trauma is an emotional response to something like an accident, crime, any natural disasters, physical or emotional abuse, neglect, experiencing or witnessing violence, death of a loved one, war, and many more. Trauma cannot be a single definition. Trauma is something that is an important event for the patient suffering from it, and that creates its repercussions. So it can be a wide variation of the definition, something that can be experienced as trauma to some people. It may not be a traumatic experience to anybody else, or vice versa, of course. It all depends on how the patient responds to it, and sometimes it's not a single event. There's no one clear trigger. It's just multiple small events that go through it. So we really cannot just point to one single thing sometimes. What is PTSD, or how does it present? Well, the most common presentation is just the thoughts, nightmares, and flashbacks are the common of past traumatic events, avoidance of reminders of the trauma, people trying to not be reminded of what happened there, hypervigilance, sleep disturbance. I think this is one of the cardinal features when people just have nightmares or PTSD repetitions, and this all lead to considerable social, occupational, and interpersonal dysfunction. If you have any questions or comments, by all means, at any time, let me know. This was shocking to me while I was making this presentation. How common is PTSD? And it is around 6% of the US population. This is 18 million people in this country. And just as a context, this is the same amount of people as the veteran population of Asian descent, or people above 75. So I'm pretty sure all of us know a veteran, somebody who's of Asian descent, or somebody who's above 75, and that is how common this condition is among Americans. Especially in some populations, Arkansas or the Southwest region has a higher prevalence than the national average, so it is even more common in the area than nationally. Of course, other subgroups, especially Native Americans and veterans, have a higher risk of PTSD. In Native Americans, it's 14 to 16% of the population who has suffered from this condition. The risk factors for PTSD, of course, the history of trauma, less education, a lower socioeconomic status, or child adversity, or ADEs is called, including trauma or abuse. And as I said, maybe not a specific trauma, just repetitive micro-traumas can lead to PTSD. Personal and family psychiatric history is a risk factor, poor social support, Physical injury seems to be highly related, especially with brain or head injuries as well. And then the severity of the reaction of the traumatic event also is a risk factor. The types of the trauma that we can experience, well, sexual assault is by far the most common one, especially in female patients experiencing PTSD. 1 out of 3 women with PTSD had a history of sexual assault, including rape or other kind. Mass conflict and displacement in this current world and conditions. We have, unfortunately, many mass conflict and displacement patients. This analysis took over 64,000 refugees, and they found a prevalence of 30.6%. So 1 out of 3 of patients who have experienced mass conflict or displacement suffers from PTSD. Combat. We all know that combat and veterans, actually most of the studies of PTSD are from the VA because it is such a common condition in this patient population that we get most of the information out of their treatment plans. Especially with severity of physical problems, they are seemingly related to suffering PTSD. Physical injury, self-perceived fear of death. If we think we're going to die during an event, this puts us at risk of developing PTSD afterwards. And this was interesting to me as well. When we present to the ER with a heart rate that's about 95, for context, 60 to 100 is normal. So not even abnormal heart rate, just being faster than the average seemed to be a risk factor to develop PTSD. And if we are suffering from acute pain or high levels of pain, this also is a risk factor. Medical illnesses. Myocardial infarctions or acute coronary syndrome induced PTSD is up to 12%. Working in hospitals, I can tell you, we see acute coronary syndromes and STEMIs or heart attacks at least 5 or 10 times per day. So almost 1 out of 10, a little bit more of these patients can suffer PTSD. So this clearly is a high risk factor. Stroke, intensive care unit stay, and even obstructive sleep apnea, that is a very common condition as well, which means that we are not sleeping okay, and people who snore too loudly and stop breathing in their sleep, they can have some PTSD related to this condition. Childhood trauma, of course, most individuals who experience PTSD trauma in childhood, they show a greater difficulty with affect regulation. They have more dissociation, more somatic symptoms, which means that they feel more symptoms in their body. So PTSD can have a wider range of presentation. It's not only the nightmares and the avoidance of the events, it can also be felt. People can feel nauseated, can feel headaches, can feel abdominal pain, and this is related with childhood symptoms or childhood adverse events as well. And then self-destructive behavior and suicidal behavior, of course, which is the final consequence of this unfortunate condition. There is not a clear thing that we know that this is how PTSD happens, because all the trauma events are so different that we cannot tell you exactly what happens in the brain of each patient that has PTSD, but some of them share a bunch of common things. And the fascinating aspect of it was that even in imaging studies, in functional MRIs, we can see brain differences in patients with PTSD compared with patients who do not have PTSD. So decreased volume of the hippocampus, of another area is the amygdala and cingulate cortex as well. This is a patient with PTSD with their eyes closed, for example, down here, and you can see the control ones. And this is the activity of the resting eye cortex as well, and you can see how it is hyperactive in patients with PTSD, meaning that they are thinking or experiencing more images while they're resting than people without PTSD. This is just a very complex explanation of saying, hey, people with PTSD have higher fight or flight hormones, but with other receptors acting properly, and lower stress hormones obviously, but the stress hormones receptors are actually hyperactive. So they kind of have this weird combination of having more stress hormones in their body at some point, with the receptors getting used to it and not acting appropriately, and then at the same time, the glucocorticoid, another kind of stress hormone receptors, they are hyperactive, so even with lower levels of this hormone, they can just have the same effects. Genes and previous exposure to trauma also appear to increase the risk of developing PTSD in the long term. How do we diagnose it? Well, it depends on how the patient presents, but there are a few technical questionnaires that we can use. Most people have flashbacks, severe anxiety, dissociative episodes, fleeing or combative behaviors. They can compensate by avoiding experience that may have the, triggering the symptoms, and this can result in emotional numbing, diminished interest in everyday activities, and even detachment from others. People can just not present as somebody who is having nightmares or who's altered, just somebody who's not present, somebody who does not have the same emotional response or connection as somebody who does not have PTSD. Nightmares are pretty common. Almost 90% of patients have at least one nightmare per week in a VA study. As I tell you, most of the information is from the VA that we have. This is an interesting story. This was from the Medical News Today article, and this is a patient who decided to share this. He said that he lived with complex PTSD and he experienced nightmares regularly. They are suffocating. That is the first word that comes to my mind when I think of them. Vividly remember every nightmare I have and often write them down when I wake up. I wake up bruised most mornings, and sometimes I wake up with cuts. When people talk about PTSD, they usually focus on the flashbacks and the mood swings. They forget about the nightmares and the issues with sleep and how it leads to you feeling drained of all your energy, constantly fatigued, and borderline terrified of falling back to sleep. Emotionally, it's even harder because you're focused to relieve twisted variations of your fears and trauma every night and wake up feeling more terrified than you were when you were falling asleep. It is taxing and debilitating, and it feels like things will never get better. This patient used therapy and mindfulness, and it helps a little. Some nights I dream normally, and it's peaceful, but I also know the nightmares may take a while to go away forever. It's all about learning to live and cope with it. I don't have PTSD, but I can't imagine being afraid of going to bed every night. This is distressing, and this is something that we need to take into account with patients suffering from it, because it's not only every day, it's every night. And I can't imagine how hard it can be. Cardinal features the traumatic event. So as I told you before, many have history of multiple traumatic events, and they may begin in childhood. Some people who are first responders, like police officers or firefighters, they may not even recall what caused the trauma, but they have the symptoms of PTSD. In this Las Vegas shooting in the 17th, for example, most of the survivors are experiencing PTSD and depression afterwards. Intrusion symptoms, also known as re-experiencing, are the hallmark. Unwanted memories of the trauma, frequent nightmares or flashbacks, as we discussed. They can be associated with fear or panic or just somatic symptoms. As I tell you, people may not recall or may not appear to be afraid or panicking or have any emotional symptoms. They may have a headache every time they drive by a certain place. They may have nausea, abdominal pain, or other uncommon presentations. They may avoid going to places that will remind them of having this experience. And this can lead to impairment of activities of daily living, like driving, a crowded place, or specific places where trauma occurred. They can have negative conditions and mood disorders. Depression and negative mood can be the initial presentation of PTSD. They can have difficulty experiencing positive emotions. So it's not only that they may feel drained or depressed, they may just not feel able to feel happy or connected with other people. And they can feel guilt about the event. The most common thing is the survivor's guilt, where people fear or feel that they should not be alive. When they experience something that their loved ones or relatives or people around them had a very traumatic experience and they walk out without it, they may feel guilty about it. This was from today, for example, the patient who was able to survive a plane crash in India. 242 people passed on this plane crash, and there was only one survivor. So this is the patient who may feel survivor guilt. Patients may initially present with symptoms of irritation or aggressive physical or verbal behaviors. They can include reckless or self-destructive behaviors like substance use disorder. They may feel an edge, being easily started, decreased concentration, and sleep disturbances as we talk. In this VA, for example, they even have a brochure about PTSD and substance use disorder. Some people just need or look for treatments, and when they can't find an effective treatment medically, they will just look for whatever they can get a hand of to treat their symptoms. And up to 1 out of 3 of patients with PTSD in this VA study can have some substance use disorder. Another subtype is the dissociative subtype, and they may include an ability to remember aspects of a trauma event or loss of awareness of the situation, so people may not even recall the trauma. What also happens with PTSD, or what other conditions can occur with it? Psychiatric conditions are the most common ones, of course. Depression, anxiety, and substance use disorder, as discussed, are 2 to 4 times more prevalent in patients with PTSD. And as I discussed, substance abuse or misuse or use disorder is sometimes, or most of the time, a patient just attempting to treat their symptoms, self-medicating with whatever they can get a hand of. 20% of people with PTSD have used alcohol or other substances to reduce tension and to try to treat their symptoms. Personality disorders, they are also higher occurring in patients with PTSD than patients without PTSD. Antisocial personality and borderline personality disorders are higher. Somatic symptoms that last more than 6 months, they can be a hallmark on PTSD, and this can feel fatigue, headache, just being dizzy, bloating, or nausea. Sometimes we have patients who we see for months and months and do many studies, and we can't find a physical cause for their symptoms. And digging a little bit deeper, there is a psychological root. And I don't like to dismiss patients' symptoms, and I don't want patients to get away feeling like their symptoms are in their head, because this is not real. Their symptoms are there, are just caused by different conditions, and sometimes we just need to treat this condition to treat their symptoms. But because we cannot find any physical causes or of symptoms, doesn't mean that they don't have anything. It means that they have something that we need to be treating in a different way, and this something could be PTSD or other mental health disorders. It's challenging. It is hard, because when somebody has abdominal pain that does not get better, every time they eat, it hurts, and we cannot find something. It's hard for the patient, or even for us as providers, to associate physical conditions with mental health disorders. But it is there, it's documented, and if we can treat the mental health disorder, we can resolve the physical symptoms. Comorbidities, so it's not only the mind that is affected, it also can affect the rest of our body, as discussed, and even autoimmune conditions. So endocrine conditions or autoimmune disorders are more common in patients with PTSD. It's just these chronic levels of stress and this hormone dysregulation that we talked about before. It causes physical damage in the long term. So maybe it's kind of the chicken and the egg. What happened first? Maybe the somatic symptoms cause some stress, and then they have a PTSD on top of that, and then we have another one. So it is challenging to disentangle this whole symptom, but it is related. The dementia, autoimmune symptoms, even Alzheimer's and vascular dementia, they can be related to PTSD as well. And people with PTSD have a higher rate of these conditions than patients without it. Parkinson's disease. Parkinson's disease is more common in patients with PTSD. TBI, or traumatic brain injury. TBI and PTSD have a high rates of recurrence among civilians, especially among veterans or people who were in war. And this is a study post 9/11 of PTSD and associated health burden, and it just proves that patients have not only the psychological condition, but also the physical conditions accompanying it. IBS is very common. I think daily I see at least 5 or 10 patients who have IBS, and this has a higher rate of patients with PTSD. This is just a study associated with it, and it just says that PTSD is associated with an increased likelihood of IBS. What will happen when a patient has PTSD? What can we expect for them in the long term? Well, it is a chronic condition. Only 1/3 of patients can recover at 1 year, and up to 10 years afterwards, 1/3 of the patients have symptoms still. What can we use to diagnose this? I just click this. This is the one that we use in our clinic. It's just a questionnaire, and I'm going to be broadly from it. And it's just especially ask initially the trauma, if we have any trauma effects, and these are the most common causes of trauma. We even have an option here when we cannot find one of them that matches the patient's trauma. They can specify it here. How long ago did it happen? If it happened directly to the patient or just witness, if somebody's life is in danger, if it was sexual violence involved in this traumatic experience, and then how this trauma has affected the patient are the next questions. And the higher the score that we have, the higher the risk or the prevalence of PTSD is. And this is one of many questionnaires and tools that we have. Now, how do we treat it? This is the million-dollar question, and I'm going to tell you like 10 or 15 different ways that we have found to treat PTSD. When we have many treatments available for one condition, is because it doesn't always have a one solution. So it is, as I discussed before, a complex situation, and not all patients respond as well as we wanted. So we have very different options that we can use to treat patients with PTSD. When? As soon as we diagnose them. I think we should start treatment as soon as we have PTSD in our diagnosis. And what do we expect from the treatment? Well, for them to maintain safety of the patient and other people, reduce symptoms, reduce avoidant behaviors, address comorbidities, and improve their adaptive behaviors, of course. The main treatment is the psychological counseling. So the trauma-focused psychotherapy, it is by far the most effective and the best treatment that there is for PTSD. We have medications, of course, but they are not as effective as the psychotherapy, and usually they go hand with hand. I tend to tell patients that this is like diet and exercise for diabetes. The psychotherapy is something that they need to be doing, and the medications will help. They will at some point, but if we don't do the basics like diet and exercise, it doesn't matter how much medications I give you for your diabetes. If you're still eating cupcakes and soda every day, your diabetes will not be controlled. And the same with PTSD. It's a chronic condition that needs psychological treatment, and if you don't get the treatment, doesn't matter how many medications I give you, sometimes it's really hard for people to improve, because this is the basis. This is what we should be establishing as the baseline for the treatment to be effective. This is a meta-analysis just saying that trauma-focused psychotherapies lead to greater improvement in PTSD than any medication out there from the VA. If we are going to use medications that we don't have to use, but if the patient requires them, SSRIs or SNRIs are a good medication starting point. For nightmares especially, there are medicines out there that can decrease the rates of nightmares. There are mixed responses. Some studies say that it was effective, and some of them said that it was not any different than nightmare. But I think it's worth giving it a shot when people are experiencing recurrent nightmares that prevent them to go into sleep and resting. There's a medicine out there that can help. Some people have psychosis. Some people can have hallucinations, or some people can experience different visual disturbances or auditory disturbances, and they need to be treated with antipsychotics, and antipsychotics are useful for PTSD. This is the CAP score, which is just a score that we use for diagnosing and following with PTSD, and it improved when people get antipsychotics when they were getting psychosis. For how long do we treat? Well, at least they said 6 months, at the very least, for us to be able to see an effective treatment, and then slowly weaning people off these medications can help, but no shorter than 6 months. And it doesn't have to have an endpoint. If people are getting better with this treatment, we can continue it indefinitely. As blood pressure medications or as diabetes medications, we can taper them off at some point. Yes, we can. If your sugar is better controlled, we can just take it off, of course. But are we going to aim to take it off at some point? We don't have to, because if you're doing good without any side effects, why would we just pull a medication that is helping you? And if you're going to take it forever or for many years, so be it, as long as you're functional and feeling better. They are another type of treatments, of course. As I told you, when we have 20 different treatments, it's because not all of them are highly effective. This is a new medication, brexpiprazole combined with sertraline, which is an SSRI, seem to have some promising results. This is an article from this February, for example. Benzodiazepines are widely used for PTSD. Benzodiazepines are medications that can depress our CNS, and it seems obvious if you're on edge and stress and you use benzodiazepines, you're going to feel better in the short term, but in the long term, it's not proven to be effective. And actually, it's proven to have worsening PTSD symptoms in the long term. Benzodiazepines are addictive, and they cause dependency, and they cause for you to get used to the dose. So you will need higher and higher doses of benzodiazepines to achieve the same clinical effect in the long term. And as the studies show, it is not effective to use it for very long. It is like having 3 shots of tequila, is what I tell people. So yes, it's going to make you feel better. Yes, of course, it's going to make you feel better because you're going to be relaxed. Can you have 3 shots of tequila every morning for 10 years? No, you can't, because it's going to cause harm in the long term. Ketamine is a novel one. This is an anesthetic that we use in the hospital, and it has been widely studied recently for all sorts of psychological conditions, including depression and PTSD. We have a couple of ketamine infusion clinics here in Fayetteville, and they have been showing some promising results. It is not guideline directed, it is not a first-line treatment, but it's out there. And for people who have tried psychological counseling and SSRIs and primary treatment and it's not working, we can use it as a tool. There's a recent study saying that it's a promising option for PTSD and no big side effects were noted. Marijuana. Arkansas legislation allows us to prescribe medical marijuana for patients with PTSD, for example. There is a mixed bag of evidence as well. Some studies say, hey, it may be effective. Some say it really is not effective. Most of them have a high risk of bias, meaning that they are not clearly associated with a benefit, and especially patients feel like this is helping, so it's hard to notice a real clinical response. I still prescribe it. If a patient wants to use marijuana for PTSD and it feels like it's helping, patients are going to use marijuana with or without a prescription sometimes, and it's just safer for them to have a prescription and get some medical marijuana on it. And as I told you, if they feel it helps, by all means, it would not cause any harm. Anything smoked is not good for you, so I try to tell people not to smoke it, just use it in a different way. But if it helps, it helps. This was interesting to me because we have a couple of clinics in town that also do RTMS, which is transcranial magnetic stimulation. And this is a big magnet that you can attach to your head for 20 to 40 minutes daily for a few weeks. And it seems to be improving PTSD symptoms in some patients. Again, a mixed bag of evidence. Some say that it's effective, some say that it's not. Most of the evidence is used for depression, but just having a big magnet on your head and feeling better, I don't think it's any harm at all. And if it can help, by all means. There are a few studies with ecstasy. So this was also interesting. In the US, we don't have the facility to use these substances for clinical trials, especially not in Arkansas. But there are some clinical trials out there saying that, hey, combined with a very specific, intense form of psychotherapy, it seems to have good response. But as I told you, the psychotherapy is the base, and then people with psychotherapy without ecstasy did not do as well as people with psychotherapy with ecstasy, but all of them had psychotherapy. So we need to take that into account. This was patients that had a very intense session of psychotherapy associated with the treatment. Just another study saying that we need more research to check the advantages and risks of ecstasy in the treatment of PTSD. This is just a blockade that we can use in one of the nerves of our neck that seems to have some result in PTSD symptoms. You're going to see this over and over again, mixed results in the treatment of PTSD because some studies say it's effective, some not, but it's not a big procedure. They just go and numb some of the nerves in your neck and people can have good response to it. Again, I think it's worth a shot if we have tried multiple other things, or we cannot access ketamine, or we cannot access ecstasy, or we cannot access high-intensity psychotherapy. It's something to take into account that we may be able to use that can help the patients. And acupuncture, I was not a believer. I swear to God, I was not a believer of acupuncture for any medical conditions. And lately, I've been like, well, it helps. There's some evidence out there, and it's not harmful in any way. And it's proven to help chronic back pain. It's proven to help depression and proven to help PTSD in some articles, and it does not hurt. It's just needles in your neck or your head. Again, if it's covered by insurance or you have the flexibility to pay for it, I think it is much safer than benzodiazepines or other treatments. So please give it a try if you have tried something else. It may be helpful for you or for any other patient. And this is just a memory-directed acupuncture therapy and just some studies saying that with psychotherapy, acupuncture seems to have some positive impact in patients with PTSD. This was it. I don't have much information. As I told you, this is mostly a psychological and psychiatric condition. I'm a primary care provider, so I don't do acupuncture, I don't do nerve blockades, and I don't do RTMS, but I can refer people to have this done, and mostly what I do is refer to a psychological counselor and start treatment like SSRIs and antipsychotics, and the medication for nightmares is as far as my scope goes. But there's a bunch of treatment out there, there's a bunch of information, and this is what I have for you today. Any questions that you have or something that you would like to discuss?
Thank you. I'm curious, what are some treatments that you found to be helpful for the people that used to have IBS?
For IBS, it all depends. Especially if we can find a root cause of the IBS, that's actually start with an elimination diet, because some people, my wife is here and she can't eat, some veggies, and because it made her bloated. I can eat veggies all day long and it doesn't make me bloated. If I drink soda and I have a cupcake, I'm gonna be bloated all day long. So it all depends on what triggers your IBS symptoms. It's very specific and very different for each patient. So I just say, hey, just eliminate some things of your diet first, and then we'll see if you respond. And of course, there's some constipation and diarrhea associated with IBS. So if you have constipation, have more fiber. You have diarrhea, maybe try some Imodium, and even some fiber for diarrhea. I find it helpful too. I don't get sponsored, I don't know if I can say brands, but Metamucil, I love it. I use it every day and I recommend it for every patient, so that's my go-to usually. Any other questions? Okay. Well, thank you so much for coming by, and if I can be of any assistance, let me know.
Thank you.
Thank you.